So when I talked to you've seen this slide before about what is West Nile virus. It is an arbovirus. It can infect and cause inflammation in central nervous system of humans. The genus is flavivirus, and it's a single-stranded RNA virus. Now, I've highlighted dengue, yellow fever, Japanese encephalitis virus, JEV, and a tick-borne encephalitis. These are all flaviviruses. Does anyone here know what they have in common? I'm sorry? Neurological. Actually, flaviviruses in general, that's a really good. Flaviviruses in general are what we call neuro. So once they infect a host, and we are the human hosts, the viruses seek out neurons. So they're known as neurotropic. They seek out neurons to infect. There's something else common about these. That is that they all have vaccines. And so I'm going to talk a little bit about vaccines at the beginning of this presentation, but there are some very notable viruses here. Yellow fever, essentially I've mentioned the Panama Canal experience and how the yellow fever vaccine was actually the first of the flavivirus vaccines to be approved, and that was in the early 1930s. That was followed by the Japanese encephalitis virus. Think about Japanese encephalitis virus as actually slightly more virulent, more neuroinvasive West Nile virus, and essentially that's what that particular virus does. And the tick-borne encephalitis also causes a very wicked encephalitis. And these are transmitted to humans by the bite of infected female mosquitoes. The females are the ones that need the blood meal to prepare their eggs. So what about a West Nile virus vaccine? Do we have a vaccine? Sorry? Yes, we do. In fact, we have 3 commercially available vaccines. So I have this cartoon here, and it sounds, or it looks like for a time being, we're going to be essentially getting used to covering ourselves with DEET and doing what we can in terms of mosquito control for control of West Nile virus infection. So yes, we have at least 3 equine vaccines available for West Nile virus. This is actually, these were after 1999. This is a nice cartoon showing the protection that we humans now should adhere to. But from 1999 through 2004, there were about 25,000 horses that became infected. And about 1/3 of those had either died or had to be euthanized. And so it became apparent that this virus, West Nile, targeted horses at greater frequencies than it did humans. And this is going to be one of the factors that you're going to see with the development of vaccines. The number matters. So I want to talk just the basic phases of the clinical trials, and most of what I'm going to show you here actually applies also to vaccines. There is a phase 0, and that literally explores if and how a new drug may work. These are mainly lab or animal studies, actually can be also performed on human beings. A good example would be, in a human, would be injecting a patient who has cancer with a drug, and then determining whether or not that drug actually goes to the tumor. That would be considered maybe a phase 0 study. Phase 1 is, you ask the question, is the drug safe in people? And the aim is to find the highest dose that can be given safely without serious side effects. In terms of vaccine development, it is a vaccine that does not cause adverse side effects. Phase 2, does the treatment work? And phase 2 is typically trials of less than 100 patients. But you determine on phase 2 whether or not there are any adverse side effects that were overlooked in phase 1 trials. And number 2, whether or not the small group of humans that you used as host or samples actually benefited from treatment. Phase 3, is it better than what's already available? And this is applicable to drugs, but in terms of vaccines, we look for a drop in the number of reported cases. And these are large trials, typically over or often over 1,000 patients. And patients are typically randomized to get either a standard drug or a new drug. In terms of vaccines, they usually aren't standardized. You either get the vaccine or you don't. Sometimes you can be injected with what we call a placebo to determine if there is a difference. Ideally, neither the doctor nor the patient know which patients actually receive the treatment. And this is called a double-blind study. These are typically carried out in multiple centers, a multi-centered, blind, placebo-controlled study. And they are expensive. This is really where a lot of the R&D is very important, and this is where the costs start essentially ballooning. So we do have the licensed vaccines for a number of flaviviruses, and there are different technologies available to create a vaccine. The yellow fever vaccine and some of the older vaccines, they had what we call attenuated strains. And these are chemically inactivated viruses or attenuated in terms of their neuroinvasiveness. Either treatments with hydrogen peroxide, formaldehyde, or other chemicals, and either inactivate or weaken a virus. And then that same virus can be injected, but it does promote an immune response, an immune response. And what we're looking for are neutralizing antibodies. So almost all vaccines work on the premise that if you inject the vaccine, it will create an immune response, and that immune response will be consist of antibodies, and these antibodies essentially attack and neutralize the invaders. But there are also a number of novel, sophisticated techniques, recombinant proteins, that can also elicit an immune antibody response. Virus-like particles. On these virus-like particles, you have to have a structure on these particles that actually overlaps that of West Nile virus, where the body may produce antibodies, but they won't be the appropriate antibodies. You have these called RNA replicons. And these are fragments that also trigger the neutralizing antibody. These chimeric flaviviruses, they literally take, this is from the old mythology, where you'd have, for example, in Greek, you'd have a creature that had the head of a dragon and the body of a turtle, or the torso and head of a human, and the lower limbs were the legs. And so you take bits and pieces and portions of different viruses, merge them together, and they actually also appropriate antibody response. And then you have viral vectors that express these West Nile virus genes. It's the genes, once you have the genes expressed, you will develop an antibody response. And it's interesting because when we look at some of the clinical studies that were done, what we see here is that almost all of the studies, this is from a review in this year, a few months ago, and what we see is that most of the studies here, irrespective of the technology used, this was an inactivated virus using hydrogen peroxide. It elicited the neutralizing antibodies in half of the individuals with 2 doses. The experimenters now plan on giving a 3rd dose to get the antibody production in a higher proportion of patients. This number 2, inactivated West Nile virus. This is inactivated using formaldehyde, and it has neutralizing antibodies after 3 days. And recombinant, this is a chimeric with yellow fever vaccine. They take their yellow fever vaccine and make the changes so that it does express West Nile virus structures that can then elicit or trigger an auto antibody response. But you see here, these 89% of individuals had neutralizing antibodies. In this particular HBV recombinant E protein. The E protein is the envelope protein of West Nile virus. It is what gives it its spherical integrity. It's what we call a structural protein, extremely important. And that E protein is the trigger to many of the vaccines. Also in other flaviviruses. And then you have this DNA plasmid that expresses also the E protein and the M proteins. But all of these, if you look here, what you see is they have, you know what, excuse me. I thought they were able to see my cursor and they're not. So I'm going to need some way so that they see what I see. Okay. So if you look here, neutralizing antibodies in greater than 90%, individuals here, 100%, 89%. And what you see is that irrespective of the actual technology, it's relatively easy, I say that humbly, it's easy to actually promote a neutralizing antibody response. So this here, so the general conclusions from these phase 1 and 2 vaccine immunization studies, this is from the review. Number 1, protection from West Nile virus can indeed be achieved by a variety of experimental techniques. Number 2, there's a major component of protective immune response are the antibodies that are directed against this structural E protein. E critical for the structural protein, for the virus assembly. Without that structure, you're not going to assemble the actual viral particles. It also induces the immune response, and it's a major component of all the successful vaccine candidates. And E protein-based vaccines are protective against West Nile virus, the strains that cause human disease. There's actually about 5 different West Nile virus strains. I rarely talk about it, but strains number 1 and 2 are the most pathogenic. This gives you kind of an idea of, this is your West Nile virus, the viral particles. This is West Nile and antibody fragments. These are fragments for our purposes as the IgM neutralizing antibody that binds to the virus and essentially clears the virus or helps to clear the virus from the and this is actually the E proteins. The E proteins is this area, the tangled area in the middle, and this is what gives it the spherical dimensions, but it's also what elicits this is the antigens that elicit the antibody responses. So some facts that were gained from this particular review is that we can obtain West Nile virus in humans. None of the phase 1 or 2 vaccine trials reported adverse events or safety concerns that could impede further clinical testing. So they went from phase 1 to phase 2. Some of them did, some of them stopped at phase 1. I think there were one or two that actually went to phase 2 and then also deemed successful. And this is from the author. In light of successful developments, a human WMV vaccine should already be on the market or in final phase of clinical testing. None of the clinical studies proceeded after phase 2. So whether or not they were successful, and they were successful at producing the neutralizing antibodies, the further testing was discontinued in most cases a few years ago. I think I mentioned that back in 2002 and 2003, when queried, I would always respond, yes, we have a number of commercially available vaccines that are in the development, in the phases of development. And I expect this to happen, in the next year to be a phase 3 trial. And by about 2006, I wasn't so convinced about vaccination. And by 2010, I pretty much stopped talking about it. Today, there is still no human WMV vaccine, and there is no candidate even close to licensure. I'm going to mention a few things here because this was this came out in the Northside Sun just I think yesterday, and about still a threat on page 1 here. And Northsiders learn no vaccine, but good treatments for West Nile. And this is regarding one of our newest members, Jim McIntyre. And so this was the reporter from Northside Sun who reported he had a conversation with Dr. Anthony, the director of the National Institutes of Health, at least the infectious disease portion of the NIH. And Dr. Fauci commented on development. And inoculation vaccine to market would likely cost more than $1 billion. While there are only a few thousand reported cases of West Nile virus in North America each year. In a bad year, you get up to 5,000 or 9,000 confirmed cases, Fauci said. Well, you want to get a vaccine with a high usage and payback. The reality is, I think he understands that there's no vaccine that's going to be on the horizon. And one of the major reasons is what he's touching on, okay? There are, if we look at the literature, there are a number of reasons for why a West Nile virus vaccine is not or maybe should not be pursued. But one of the reasons that we see is that it's an elderly population primarily with an aging immune system, and it's called immunosenescence. And when your immune system actually ages, there can be safety concerns. And so remember, we're giving a live virus in several of the vaccine techniques. You actually inject the live virus. It's been weakened, it's been attenuated, and it's been inactivated. But if you inject it into someone who's 60 or 70, that sounds young. Okay, 70 or 80. Okay, 80 or 90. If you inject it into someone who's 80 or 90, you don't know whether or not their immune system will be strong enough to fight off even a weakened virus. Throughout history, that we've actually seen that happen. I hate to say it repeatedly, but enough times. It happened with the initial polio vaccines. There were several deaths after injection or presentation of the vaccines. Second, but one of the counter arguments is that a variety of techniques. It's not just the inactivated virus. There are a number of variety of that don't employ inactivated or weakened viruses don't include the live virus, and they also induce very good, very high titer neutralizing antibodies. Another reason submitted is that elderly require higher or more doses. But all these phase 1 and 2 trials actually had a group of elderly people. That was just not the case. They were able to produce the neutralizing antibodies and did not require a booster. However, if we talk about getting a booster, what does that imply? It implies, yeah, actually more costs. Instead of spending, essentially this much for West Nile, now you think about a booster, and you're kind of now this much more. Okay, so not necessarily a good thing, depending on which arboviruses they're trying to control. Difficulties in clinical study design has also been offered as a reason for why there's no phase 3 trials. But the reality is there are multiple flavivirus vaccines already in existence and for decades. This is at this point, it's not rocket science. You can actually use some of the literally build upon the prior vaccines and the prior discoveries and the prior techniques. And the last one is the economic considerations. And the other issue, virus outbreaks are sporadic. Some years, even in Mississippi, we've had over 200 cases twice, and we've had as low as 20 or 30 cases. If you have to give a vaccine, you need some way of trying to assess and evaluate the from giving the vaccine. And that may not be so easily done in a virus that may have 10,000 cases 1 year in North America or in the United States, and the next year have 2,000 cases. Final one is the cost. These now routinely exceed $1 billion. And it's easy for a pharmaceutical company to actually run the numbers and realize that they're never going to recoup that investment. Okay, and so it should not be done. I devoted the last 20 years of my academic life to West Nile virus. I wish it were done, but earlier today, Sharon Sims, who's the president of the Mosquito Illness Alliance, asked me, "Are you going to talk about triple E, the Eastern equine encephalitis?" And I said, "No." And so she filled me in on all the number of cases. How many horses in Mississippi?
10 horses that are testing positive for E.
So 10 horses in Mississippi testing positive. I extrapolate that across the country, that may be a large number.
It's a big year for each, which is a totally different virus than West Nile virus. It's much worse. Symptoms and mortality much worse. I've heard a lot about the Northeast that is having a lot of cases. There's been a female who passed away in her early 50s, and there's a girl that's on a ventilator. We have had some extreme human cases here. And children under 15, if they get Eastern equine, chances are they are not going to survive it. So we have to take those prevention measures whenever you're outdoors. The 10 cases are by county on the State Department of Health website. Exactly where each is, but have 4 cases on the coast. The entomologist at the health department, she is trying to get the cities and towns to catch some mosquitoes, do some surveillance, and have those mosquitoes tested. See if we have positive mosquitoes in the state of Mississippi.
Okay.
We'll that in the next couple of weeks.
I thought you were going to maybe say one sentence, but if you say more than one sentence in the future, no, I understand. So please come up here. Okay, so this is a webinar. Okay. So yeah, actually, what you said was actually very good, very important. So
Thank you.
I'm sorry to make her repeat this. Okay. So the issue was
This is for the outside people. Okay, we're doing a live webinar. So I have information on the state of Mississippi as well as nationwide. We've heard a lot in the news about Eastern equine encephalitis, which is a totally different arbovirus from West Nile virus. If you had West Nile virus, you are not immune to Eastern equine, so you still need to take the protective measures to protect yourself for Eastern equine. Here in Mississippi, we have 10 horses that have tested positive for Eastern equine. We have not had any mosquitoes that have tested positive as of yet, but we could potentially have some human cases of West Nile. Bad year for it, and they just kind of come around every 10 where we have sporadic up and down, but it is a much higher mortality rate. Kids under 15, if they get it, chances are they're not going to survive it. And the elderly also compromised immune systems. It's a pretty nasty, and you should be hearing more about it because there will be continued cases. It's mainly right now the higher numbers up in Michigan and Massachusetts and up in the Northeast.
Not like West Nile or
I think that they have a lot of health alert networks, which is a system that the CDC uses. So they are sending out information to the hospitals and to the physicians in those areas.
one other question. Roughly how many cases in any given year in the United States of EE?
I was looking at website, and on their website they have from 2009 until 2019. 2010 they had about 10 cases nationwide. 12, which was also a big year for West Nile virus, they had 15. And like I said, the mortality rate is very, very high for EEE. This year, but CDC website, they're about 2 to 3 weeks behind on posting. Right now we have 9 cases nationwide, but it's probably more like 15 to 18 because they are behind on updating their website.
So I actually, thank you very much, Sharon. So I mentioned the EEE. So because I'm not negative on pharmaceutical companies. They need, and we need to spend more money on their R&D. So we have here an issue. How many, if I ask you show of hands, how many think that a West Nile virus vaccine that is actually at the tip of our fingers should be essentially approved with a phase 3 study? I think most of us here would raise our hands. If the same question, how many think that a vaccine should be directed at EEE? You know, the reality is there is this is what I meant, a few minutes earlier, that numbers matter. Probably very few of us that would say, we could do a lot with $1 billion instead of creating a vaccine that's going to help on average 5 to 15 lives a year. And let me tell you just one other thing about vaccines. I think it was last year or the year before that fever vaccine, once it's approved, and that's been approved for decades in the 1930s, and it's a very effective vaccine. But still, there were outbreaks and epidemics. And I think that in the last few years, there was a yellow fever outbreak, and about 20,000 people died. So you start realizing that even if sometimes when you have a vaccine, you have to disseminate it properly. Even that becomes a problem in some countries where you have essentially very, very limited resources. I don't have all the answers on vaccines. I think that we will eventually have a vaccine because I do expect future outbreaks or epidemics. So we know that West Nile gained entry into North America in 1999. There were, again, horses. Now we feel a little bit more sorry for them because when we realized there were probably hundreds of horses that actually died in that particular outbreak. 2000, this is 1999, 2000, 2001. And this was one of the large epidemics across North America in 2002. It actually affected most of populated Canada as well, because most of them actually live near the border. And this now the geographic range of West Nile since 2010, 6 of 7 continents. And with global warming, it's just a matter of time. What's the transmission? We've covered this before. Blood products, organ transplants, transplacental mother to fetus. The mother to fetus is actually most prominent in and the Zika fetal syndrome with microcephaly, breastfeeding, just accidental inoculation, dialysis related. Sometimes the machines are not completely sterilized, and possibly sexual intercourse can all transmit West Nile virus. This is essentially the major cycle in nature. It's mosquito to bird. And we are literally just what we call dead end hosts because the virus, even when it does cause infection, is never the viremic phase, which is a phase at which the virus is traveling through the bloodstream, is never high enough to actually propagate the infection. Typically a summer event. For many years, it was actually known as the summer flu. And then in the 1990s, it got more invasive, and we started seeing more cases of encephalitis and meningitis. Incubation period, the signs and symptoms typically develop 2 to 15 days after the bite of an infected female mosquito. In that incubation period, there's a raging war between the virus, that neurotropic virus, wanting to enter the central nervous system and your immune system. And so the virus goes from skin to lymphatics, and from lymphatics to veins, and veins, essentially the entire vascular system. It spreads it to the spleen, the kidney, the livers, and eventually to brain and spinal cord. Application, we've seen this before. West Nile was initially thought of as a mild, self-limiting summer flu. And by definition, the neuroinvasion did not occur. Neuroinvasive disease was classified as either meningitis, which is inflammation of the lining around the brain and spinal cord, but not actual invasion into spinal cord or brain, and encephalitis, which is a severe form where the brain tissue is actually attacked and destroyed by the virus. And then there's an acute flaccid paralysis, which is actually more of a disease that affects the gray matter of the spinal cord, and that's where the motor neurons, the spinal motor neurons lie. And those spinal motor neurons are what give rise to those motor fibers that supply every skeletal muscle of the human body. So when you have an invasion, what can happen is that, let's say if it involves the cervical spinal cord, that cervical spinal cord gives rise to the motor neurons that control the breathing, control your diaphragm. Every medical student knows that C3, C4, C5, meaning cervical levels C3, C4, C5, are what keep the diaphragm alive. And we've had, several dozen cases where diaphragm was affected after a West Nile virus neuroinvasive disease. This is also missed. And so we had two cases recently in the past couple of years where the fact that these two patients, one that had weakness in the right shoulder girdle muscles that received abundant C5 supply, this young man was weak. He couldn't really lift it well, and then it started having all these myoclonic-like twitches, involuntary twitches in the same muscle groups. And this was unequivocal evidence that this was neuroinvasive to the spinal cord. But this young man also developed a abdomen, and he actually underwent surgery because it was due to his diagnosis was obstructive, a colon obstruction. And colon obstructions typically require surgical decompression. Anyhow, he underwent the surgery. They didn't really find much of anything. And this is because West Nile virus, I'll get into a little bit more later, but West Nile virus can also attack the autonomic nervous system and destroy neurons in the autonomic nervous system, which is what controls all the involuntary movements and involuntary actions of humans. Everything from how your pupil constricts to cardiovascular integrity to skin sweating mechanisms, colon peristalsis, how food gets from point A all the way out. It's all controlled through these small fiber autonomic nerves, and that can also be affected. Well, when they actually did the surgery, they didn't find obstruction, but after they extubated him, he had a respiratory arrest. So they went several days, they extubated him again, he had another respiratory. And so what was being overlooked was the fact that this shoulder was a clue that the virus had already invaded the C5 portion of the spinal cord. And again, C3, C4, C5 keep the diaphragm alive. It was probable that he also had C4 and possibly even C3 involvement, although those C3 and C4 don't have a very good representation. You have to look at trapezius and neck muscles, and no one's very good at actually looking at trapezius and neck muscles. This is a human pyramid, and this shows that neuroinvasive disease cases are now the majority of reported cases, and the West Nile fever cases are making the majority of cases. This is true pretty much since 2002, and neuroinvasive disease becomes more and more, I'm not going to say prominent or predominant. This is biased because neuroinvasive disease cases are going to be the worst cases and more severe, and they are going to be the ones that are going to compel the patient to seek out medical attention. The fever cases can be, again, a nasty summer flu would be not unusual for West Nile fever. And then you have the lingering symptoms, which I will go ahead and comment on momentarily. But so 80% of the infections cause no symptoms, but generate lifelong immunity. We think it's lifelong, certainly since 2002. And the reason is that they create and produce these or induce these neutralizing antibodies. Same thing that a vaccine is going to do. Once you produce these antibodies, yeah, you're going to have at least a very long course of protection against these flaviviruses. So West Nile fever, this is typical symptoms: summer flu, fever, chills, headache, body and muscle and joint aches and pains. The GI can be affected with nausea, diarrhea, constipation, rash in about 20% of the cases. Rash is, for example, in Zika virus is the vast majority, 80, 90% have a rash and they have bloodshot eyes. So if you see rash and bloodshot eyes, it's really probably not going to be West Nile. And Zika is going to possibly be on the horizon now that the mosquito that carries Zika and dengue and chikungunya and all the other viruses that we can't even spell in the southern United States, all the way to California. We've lost although mosquito control is still the main way of combating the West Nile and other arboviruses. The reality is we've lost major battles, and this is one. And just a social commentary: we really ought to be preparing for Zika and dengue and chikungunya. We have the mosquito vector. It's, I can't imagine that we don't prepare a little bit better than what we're doing. We have the ability to do that. Neuroinvasive disease and meningitis is a typical meningeal type of problem. You have headache, lethargy, neck stiffness is classic. We call it nuchal rigidity or meningismus. Someone mentioned a real pain in the neck. You have white cells that tell you that your immune system is trying to fight off the infection. And the prognosis for just meningitis is actually, favorable. From my experience, I'm not sure about the utility of this particular classification at all, because I have seen too many cases that were clearly neuroinvasive that were not even considered neuroinvasive. And I'm not really sure how a neurotropic virus is going to somehow limit itself to the lining of the spinal cord in a way that actually makes sense. It does not, to me, never made sense to have a category of meningitis. Okay? I see patients who have tremor, and the tremor is, after a West Nile virus infection, it's simply not recognized as being a tremor comes from the brain. If you develop a tremor after West Nile, you start thinking about some type of neuroinvasion. Involuntary jerking. We had one young lady whose one of the chief complaints was everything seemed hyperexcitable, and her leg and leg would do this and back and forth. It's something that we call clonus, and her reflexes were very brisk, and she felt jittery, and she was given a diagnosis of West Nile fever. No. I mean, the reality was it was clear she had central nervous system infection and invasion. I think reclassification may be something. Encephalitis, this is the most severe form. You have altered consciousness, confusion, coma, and often focal neurological signs. This is fatality is 5 to 15%. Again, it typically targets the immunocompromised and the elderly. All these here: seizures, ataxia, which is a problem controlling the rate and the range of movement. You have movement disorders. Again, their genesis is central nervous system. You can have aphasia, which is difficulty understanding the written or spoken language, or even speaking the language. Hemiparesis refers to half the body being weak. one arm, same leg, right arm, right leg, and half of the become weak. These are clear signs to a neurologist that the virus has essentially invaded the brain. This is one of my favorite patients. And she developed encephalitis, 102, 103-degree fever, rapid progression. She had severe generalized weakness. Delirium went to stupor. She developed bulbar signs, difficulty swallowing, slurred speech, disconjugate gaze, meaning one eye went this way while the other eye looked this way. And the consciousness remained impaired in a semi-comatose state for about 9 days. The neurologist commented, the patient is critically ill with fulminant neurological deterioration with potential for further deterioration and possibly death. It was at that time that we actually decided, let's go ahead and begin a 5-day course of really high dose steroids. After the first day after the high dose steroids, she actually was spontaneously opening and closing her eyes. Day 2, she was awake and actually, according to her husband, was actually attempting to joke with him and even cracking a little smile here and there. But thereafter, she remained awake and responsive, and she has been since given talks at some of our seminars across across Mississippi. She wrote her up, and it's one of the comments I wrote down here is that in trying to convince initially some of the doctors, not a Baptist hospital because they're actually quite good there. This is where she was hospitalized. And so, but the comment was, it's perversely counterintuitive to think we can treat or should treat brain infection by weakening or suppressing the immune system. And yes, it is counterintuitive, okay? But we have anecdotal experience dating back to 2002. I've been making this recommendation when it became apparent that the virus, West Nile virus, was very quickly cleared from the human body. And there's irrefutable, powerful evidence that the virus is quickly cleared. And I'll show that to you. It comes from CDC. Actually, I and everyone else who actually saw these patients knew that about half of them had this persistent problem. Even those who had just West Nile fever had persistent, lingering, sometimes recurrent symptoms. So this is a study I'm referencing from 1999 through 2002. The CDC reported no West Nile virus isolations from humans in the Western Hemisphere. 2,671 cases in the United States. No cases of West Nile were isolated. All attempts to recover West Nile from humans failed. And so they actually got to these patients after they had their neutralizing antibodies. The IgM was formed. They went in there. That's how you identify and make a diagnosis of a patient with West Nile virus infection, or the predominant way. The first isolated case was in late 2002, and that one didn't count. It count, but they mentioned it, but it didn't count because this was from a woman who actually had non-Hodgkin's lymphoma, a cancer, who had 3 different chemotherapeutic agents, all of which, or 2 out of 3 of which, actually caused immunosuppression. So if I remember correctly, she was not able to even form the neutralizing antibodies. So needless to say, West Nile is apparently, based on the available evidence, relatively quickly cleared by the immune response in humans. The infectious virus cannot be isolated from humans after production of neutralizing antibodies. Again, in 2002, we considered also latent infections. That means, like the chickenpox virus, chickenpox hides in the dorsal root ganglia of your body, and then when you're strained or stressed or getting old, it reveals itself through shingles. Shingles can actually invade and cause damage to the spinal cord. Again, like these viruses that can remain hidden, there's no data that convincingly shows that this occurs with West Nile virus infection. It doesn't really cause chronic infection. It doesn't hide in the human body. And so all these lingering symptoms, and particularly the ones that occurred and developed in a delayed manner after West Nile virus infection, they cannot be attributed to active neuroinvasive West Nile virus. And that's kind of all the ammunition we needed. And after that point, we actually started with our third hypothesis that we had some type of post-infection state that essentially allows all these protracted lingering symptoms to keep on occurring. Dr. Vig from the University Medical Center was actually the first to actually come to me and say, you know, I'm studying something called S100B, and that's a protein that's extremely important in ushering in an autoimmune cascade. I said, no, I didn't know that, but this is how you build the network. Dr. Vig had been working on that. He informed me of that, and now we have, half dozen papers and reviews on S100B in West Nile virus survivors. It's going to be elevated, and it's going to be elevated even higher in patients who have neuroinvasive disease, and also elevated in those who have just West Nile fever, just not as high as neuroinvasive disease. There's now a convincing evidence that West Nile does trigger a post-infectious, what we call pro-inflammatory, ongoing neuroinflammation. Inflammation is never good for the human body. It ushers in a bunch of other things, everything from just outright pain to cancer to other things that can be tracked to inflammation. And it certainly, in my opinion, does contribute to morbidity and to the ongoing symptoms in WNB survivors. We actually kind of worked out the biochemistry, and essentially, your bodies are responsible for creating the problem. The problem is the immune response. So we have a immune response that brings in all these S100B, all these other interferons, cytokines, and that is the first line of defense. That's what protects us from the neuroinvasion from West Nile. It essentially clears the virus in 80% of before we even know we have been infected. The problem is not so much that initial immune response, it's the fact that the immune response persists to create this post-inflammatory state. And that's characterized by the increased neuroinflammation, cytotoxicity, delayed neurological deficits, persistent symptoms. And that's what we have found, and probably the premier group that has studied this is the two programs in Houston, the Baylor College of Medicine and University of Texas in Houston. And I'm just going to show you this one slide. I love showing it every time. So they talked about looking at fatigue in West Nile virus survivors. So The aim was to characterize fatigue and determine if the cytokines, the pro-inflammatory proteins, played a role or were elevated in this group. And in 1/3 of the group that had prolonged symptoms defined as more than 6 months after the acute infection, they actually found that 1/3, an average fatigue duration, of 5 years. So it tells you, and if you look at their definition of fatigue, I'll tell you, there are a lot of autonomic symptoms, like GI symptoms, and tremors and things of other nature that tell me that although they elected to look at fatigue, they were looking at a lot of other things in addition. They found that there were a number of these pro-inflammatory cytokines that remained elevated even 5 years after the infection. And this is exactly what we have been seeing. This is the premise behind treating patients with corticosteroids. We're not treating the virus. Prednisone is not going to destroy virus or viral remnants. It's going to lower the inflammatory response. It is a potent anti-inflammatory. Theory, giving an immunosuppressant at this stage would probably do the same thing. Steroids do it quicker. When I treat a patient with rituximab or methotrexate, it takes a lot longer to achieve the desired immunosuppression. This is the quickest way of actually an anti-inflammatory and of suppressing the immune system. We suspect, and I think the biochemistry will show, that there is a post-infectious pro-inflammatory state, and it does other things too. It's directly linked to a number of new cases of other autoimmune diseases like myasthenia gravis. But it also can take a autoimmune disease that has been stable for years, and if you have West Nile virus, you're going to lose control of that previously stable autoimmune disease. And this particular case, after looking at and diagnosing 6 cases of myasthenia gravis, I knew that this would come up at some point. And so I kind of I talked to my colleagues at Mayo Clinic. I said, look, you see all these cases, be on the lookout for this particular. And sure enough, it took about 4 years, but we were able to show that this patient who had very, very stable myasthenia gravis, it's an autoimmune disease, but it's very, very stable. Sometimes we don't even have to treat it with anything, except with a Band-Aid treatment called Mestinon, which can control some, incipient double vision. And sure enough, about 3 months after this patient developed a West Nile virus neuroinvasive disease, he completely lost control of the myasthenia gravis and had to be placed on a artificial ventilator because myasthenia gravis also weakens the respiratory drive and the respiratory muscles. In some ways, it's like giving you a big dose of botulinum toxin, and you have an idea of what happens to patients with myasthenia gravis. And so he was actually on a ventilator for a number of days. The last classification is the acute facet paralysis, which is actually more of a poliomyelitis. I use this example to show that who was previously healthy, not elderly, and who went to the emergency room repeatedly with a complete flaccid paralysis of the right upper limb, his dominant hand. And by the time I saw him, it was about a month and a half later, you can see that right now, this is what the shoulder should look like. I'm asking him here to go ahead and raise both arms up in the air. And what you see here is just the outline of what's the name of that bone? That bone, okay? And so, but you see the striking atrophy. You also see the atrophy in the right hand here, and compared to his non-dominant hand. And just to show you this, we compare the numbers in the affected arm. Let's say, looking at his shoulder girdle muscles. This is the deltoid muscle, the big muscle that abducts the arm and helps you do this. The amplitude of the response here was 0.1 compared to 7.2. And so this individual, just by this type of this crude direct comparison of ratios, had probably lost 98% of his connections. We kind of knew this, that his prognosis for that dominant right arm was not going to be so good. And indeed, we actually did study him years later, I think in 2013, and he still was compromised. He couldn't do this. He kind of achieved it by turning his body and by compensating with other muscle groups. But his hands were perfectly normal. The implication is that you can lose roughly 60% of your motor neuron connections and then have a very good or complete recovery. This is what the virus does. This is a motor neuron. This is a healthy motor neuron with the nucleus right in the middle. This is an eccentrically located nucleus. This ballooning, this swelling of the motor neuron, and that motor neuron. This picture here is what this was, maybe 3 or 4 days before. It went from literally this to this, and later the remnants are going to be phagocytosed, which means that the macrophage and whatever cleaners, the cells are going to come up there and literally take the left over. We also have brainstem involvement. Brainstem is part of your brain, and it also targets the neurons in the brain. Facial paralysis, there's also muscles of mastication were extremely weak, and he was unable to close his mouth. The autonomic nervous system, all these automatic functions, heart rate, blood pressure, breathing, digestion, bladder, bowel, sweating, pupils, all are controlled by the autonomic nervous system. And so I would say that we probably have at least 20 cases of patients who developed atrial fibrillation after West Nile virus infection. Some type of cardiac arrhythmia, West Nile virus infection. Here from autopsy studies that it does target sympathetic ganglion cells. This is part of the autonomic nervous system that controls rhythm. It can also targets the gut. Your gut is under complete control of the autonomic nervous system. And what happens is the normal, or what we call these hamsters, hamsters were injected, but this one didn't have this bloating. This one has what we call the paralysis of the gut. We have our poster child who actually presented with delayed neurological deficits and included gastroparesis, heart rhythm problems, orthostatic hypotension. Initially, she would stand up, blood flow would go down, she would pass out. Something called postural orthostatic tachycardia syndrome. She stands up, and heart rate that should be 60 beats a minute or 70 goes up to 180. Change in sweating. She felt like her body was not regulating temperature. About 4 or 5 of you have actually complained of something very similar, having trouble regulating temperature. She started losing hair, her toenails started falling off, and she had dry mouth. The typical exam, this was her when she's not feeling the gastroparesis, and this is typically what happens when she develops this problem. She actually was one that we were able to treat with intravenous immunoglobulin immunotherapy, and she had a very good beneficial outcome in a lot of her symptoms, but not all the symptoms. In closing, is there a specific therapy? Not for West Nile. Would a vaccine be helpful? Absolutely, positively. Is there treatment? Absolutely, in my opinion. The evidence, in fact, the only evidence is the evidence from clinicians. And it does indeed present a powerful message that the after effects of West Nile virus can be treated and that they will respond. Those after effects also contribute to the morbidity, which is the sometimes disabling, recurrent, lingering symptoms. Stop right there, okay, and open it up to questions.
Slide on the pyramid.
Okay, the slide on the pyramid. Go ahead.
But the one CDC is still saying not 10%, correct?
Maybe can you get my big earphones?
I think that they're actually slowly coming around and reporting.
No, I might ask a question.
As reported cases. It's extremely helpful. I never really agreed with the concept of actually telling the public that less than 1% of cases are going to be neuroinvasive. The reality is that since onset, more than half of the cases have been neuroinvasive. That's what we see. That's what we deal with. In the 1940s and 50s,
That is a doctor?
the polio virus. And there were 500,000, its worst epidemics, 500,000 paralyzed Americans. And 90% of their cases were subclinical or essentially never reported. It has no value. So to me, the majority of cases that we're going to encounter are going to be neuroinvasive. Virus is going to gain entry into spinal cord or brain or both. So the question was, I mentioned that there was commonalities among all the flaviviruses, and the answer is yes, there are a lot of commonalities. And so can we essentially use viruses or the population countries where the virus attacks to help with West Nile virus vaccine and to do the proper evaluation? We're actually already doing that. So some of the successful phase 1 or phase 2 vaccines for West Nile actually were piggybacked off the yellow fever virus, or the tick-borne encephalitis virus. This is the chimeric methods that I spoke about. You actually borrow. And the other thing, if I were to show you the molecule for the E protein, the envelope protein, I will tell you, it looks really similar in all the flaviviruses. Now, having said that, I will tell you that West Nile virus neutralizing antibodies probably is not going to protect you against any other flavivirus. I almost hesitate to say this, but in some circumstances, it may make things worse. And how do we know that? We know it because of dengue virus. Dengue is a common, I think it's surpassed malaria at this point. It's the most common vector-related pathogenic process. And so last year, there were probably 250 million clinical cases, and probably another 200 million clinical cases. And so there's any given year, you can actually be infecting 500 million people worldwide. There are 4 subtypes of dengue. And if you get any one subtype, the first exposure, it's probably something, it'll be an infection that you can handle. Second time you get exposed with a different strain, then that can actually lead to a much more devastating outcome. Dengue toxic shock syndrome or dengue hemorrhagic fever. And it has to do with the additional antibodies and how they bind but don't neutralize dengue, but they bind it, and then the immune system comes in and takes dengue, like it does to West Nile, takes West Nile and dengue viruses where they want it to go. There is a possibility that may not make things better. Invasive, yeah. If you can't, so the issue was she was diagnosed with West Nile fever, and then she realized during the acute or subacute illness that she really couldn't read the words. And so, you know, the counter argument would be, well, if you were still suffering from severe headaches, it's going to be hard to read anyhow. She says this was different. And so, yeah, you know, when vision becomes affected, to me, under those circumstances, I would be thinking neuroinvasive disease. So she's got 2 questions. Go ahead. Okay, so question 1 was the support group talks a lot about taking B12 to help with fatigue. Is there any clinical basis for that? No. So let me just preface that. If you are B12 deficient, then you're going to need B12. And a B12 deficiency, it's a scary thing, and I've seen a lot of cases because it has nothing to do with what you consume. You may think you're taking enough, you know, through eating the leafy vegetables or red meat or whatever. But the reality is that's not the limiting factor. The limiting factor is whether or not your stomach lining, the parietal cells in your stomach, actually produce a factor. That factor is called intrinsic factor that will allow you to absorb B12. And there are autoimmune that can destroy the parietal cells and prevent you from generating the intrinsic factor. Yes, if you're B12 deficient, you're going to feel a whole lot of things, including subacute, that means kind of gradual, combined system, degeneration of the spinal cord. That's not a good thing. Okay? So you can damage peripheral nerves that arise from the spinal cord, and you can damage the pathways in the spinal cord. And if that happens, you're probably on your way to dementia also. It does all these things if you're B12 deficient. So I don't mind that patients take B12. I don't even mind that I think that most of the time it's for placebo effect. I don't mind that there are doctors that tell you, yes, it'll make you feel better, because placebos do make you feel better, okay? And because literally it's almost no toxicity from overdosing with vitamin B12. You just literally urinate out the excess, okay? So I mean, I rarely tell anyone to stop taking B12 unless they want to know. Second question, shingles shots, okay?
Any reason there should be concern other than non-steroid? Because there be any compromise?
So the issue is the Zostavax vaccine. Should there be any concern that that patients, WNV survivors, should be taking the shingles vaccine? Are they going to be more prone to developing shingles and the nasty effects of shingles? No. The answer is no. There's no connection. Certainly if I can foresee that if you have a neuroinvasive disease, you lose 30 or 40 pounds, and I've seen this before, you're malnourished, you lose your job, okay? All these things can happen, or you lose your business that you literally tons of money to start. Then you can have that stress alone can precipitate shingles. But there's no other direct mechanism that I'm aware of. Touch on the flu vaccine. Yeah, I can. I would say, let me read this to you again. Dr. Fauci from NIH. That more than 48 million, 48.8, so 50 million people contracted the flu during the 2017-2018 influenza season. 1 million were hospitalized and 80,000 died. So I don't tell WME survivors not to get the flu vaccine. Flu vaccine is literally, if you look at this, it's extremely dangerous, depending on your age and your immune system. Now, what happened? Because there's something that identifies each of you in this room. There's something about your immune systems that you weren't able to turn it off in time. Started perpetuating the neuroinflammation. I don't know what the mechanism. Maybe maybe someone will hear this talk and say, "Well, Dr. Harris doesn't know what he's talking about." It can happen, but also they may say, "You know what? We have to investigate that more." About what is it about your genotypes that allowed you to go to neuroinvasive disease? 4 out of 5, I agree with this. 80% are asymptomatic. Your immune system clears the virus before it does anything. 20% of you are not lucky. So someone should actually step forward, a group, and say, let's figure out what causes the unluckiness. What is it about your immune systems? Why do you have, like Dr. Murray and Dr. Hospoon and their groups in Houston, what is it about the virus that 5 years later can still be causing such major symptoms in the population? Outside,
First one is from Paul
Actually, okay, so, you carry your computer here? My laptop, it goes down.
In the 1999 outbreak in New York City, the mayor's office bought 500,000 cans of PAW to hand out to residents. Have any prevention initiatives been successful so far?
So essentially what he's talking about is mosquito control. And I got to tell you, mosquito control is probably, at this point, the most important way of defending against broad-borne infections, the mosquito-borne infections. And so they actually make, they did a tremendous job. And Zika actually had a minor outbreak in the Miami area. And so they literally did everything in the power, and they kept it from becoming, the next, 1999 West Nile virus outbreak. So yes, right now, without a vaccine, and Sharon, you may want to comment, but without a vaccine, mosquito control still is the best prevention. Aside from that, you have all the daily, what you go up here and say, what type of prevention will help.
I'm big about prevention. That's kind of my job of what I do out in the public is to prevent people from, because of you guys mainly. And I stress to each and every one of you on this webinar and in the room, prevention, prevention, prevention. You can keep from getting this virus. You need to wear an EPA registered product. And if you don't know what that is, you can look on the CDC website, the Mississippi State Department of Health website, and they will give you a list of all of those that are EPA registered that have been tested. There's plenty of data out there that they are effective, or they would not have that EPA registration. So there is a company in Mississippi. I don't know how many of you in the room have seen this product. They're in your co-ops, they're at Home Depot, Lowe's, all throughout the whole entire nation, this product is. I, along with others in the mosquito control industry, questioned these from day one, and they've out of Hattiesburg, Mississippi, and they have been in business since 2016. And they're not EPA registered because they don't have to be, because they changed the ingredients for this product. But it's the Spartan Mosquito Eradicator. And it's a little gadget a tube that you hang for about 3 months, depending on weather, and there's a lot of, but us in the mosquito control industry have been questioning this product from day one. And there has finally been a review of this product that is not effective. Have any of these?
Who has any review?
It's Colin Purrington, PhD environmentalist. He's out of Pennsylvania. But there have also been some other studies that this company has asked to test their product, but they had to sign non-disclosures. Therefore, they have not been able to report their findings. Colin has done extensive work on this, and we feel with the Mosquito Illness Alliance as an advocacy group that we need to let the public know that this is not an effective product based on this review, and there will probably be others. So how many of y'all have found them effective? Okay. Well, and in this, Colin will tell you his review, and I can make more copies if we need them. It goes into extensive testing that has been done and has proven that it don't work.
So. Yeah. Right. Mhm. Mhm. Good. Do you know what the active ingredient for that is? Okay, the light. Okay. I would encourage you to, right. I would encourage you to make sure that it's an EPA registered product because there's a lot of scammers out there. You know, there's a lot of, catch a lot of mosquitoes. Okay.
So what is the name of that?
Okay. One of our in-house members is talking about some type of ultraviolet light device that you set outside and the mosquitoes fly into that. Colin, you may want to look into that inside his home. We are. Her question was, are we more concerned about the dusk to dawn mosquito than the it's a daytime biter? And the answer to that is yes. That's the Culex quinquefasciatus house mosquito. And the reason why it's called the southern house mosquito is because it hangs right around your house. If you are breeding mosquitoes in your backyard, that's where they're going to live. They fly less than a mile in their lifetime. So they're going to hang around your backyard. Now, the Zika mosquito, which we do not have here in Mississippi, there's a few little pockets of the Aedes, that Aegypti mosquito that carries Zika virus, but we do have the second potential called the albopictus, which is the tiger mosquito, the black and white striped leg that you see. That is a daytime biter. You know, but you're not going to know which one that is. You're not going to be able to identify it really. So that's why you've got to wear mosquito repellent every time you go outdoors. You know, and then the active ingredient is and make sure that it's DEET or picaridin or EPA registered product. And the percentage that you purchase is more is not better. More lasts a longer period of time. So a product that has 7% DEET, that's going to give you about an hour and a half protection. If you have the 25, which is a good family product, that's going to give you about 6 hours of protection. So you need to know that. Also, the American Academy of Pediatrics says that you can put 30% DEET on a child 2 months and older. So if you have questions about your kids, it's the same way. It's 2 months and older.
Touch on the sunscreen combination products.
Okay, with the sunscreen repellent products, those there's been talk that those are going to come off the market because the efficacy of both products is not well. But since they are still out on the market, I mean, you can still buy it, but I would probably do both. You need to sunscreen first. You need to smooth it into your skin and allow it time to soak into your skin and put the repellent on top of that. Read the label instructions on the sunscreen because you're going to have to put that on more than you would reapply the repellent. Sunscreen first and then repellent.
Comment real quick. Colin Purrington in our chat group said that light will attract all types of insects. Fortunately, not very many mosquitoes. So he personally does not recommend any mosquito killer that operates with light alone. It's an interesting perspective on that. And another question for Dr. Lace is, A lot of members have questioned the 1 to 150 ratio for acquiring West Nile virus. We happen to think it's higher than the 1999 statistics say. So how do we get the CDC to update this number?
Yeah, good luck. I mean, sometimes change comes slowly. I made the comment that, the disease is, and I do occasionally see it still in reviews, where they will say it's less than 1 in 150 cases are neuroinvasive. And I just, from my experience, never has no applicability to the clinical situation. And so, I mean, we CDC and I mean, most investigators agree that the majority of cases that we're going to see that are going to be reported are neuroinvasive. And personally, I do wish that they would get away with, because it's always on the first paragraph of almost 3/4 of the review. It's the first paragraph, and less than 1 in 150 are neuroinvasive. It's just, when I see that, I just kind of roll my eyes. So hopefully, over the next few years, we will see it less and less because it has virtually no meaning. Okay.
There are medical databases. I'm asking you where I can often do not know. There's a medical database where a family member search this database, get this up-to-date information on what's the record.
Yeah, so it's a good question. So the issue was if you suspect that someone has an incipient or an acute West Nile virus infection, is there a database or is there a resource where that individual can then take information to the doctors, because doctors sometimes are unaware? Well, that's one of the reasons we actually started the support group. And it was almost a common to many, I would say most WNV survivors. They were having symptoms, and the doctors weren't. It wasn't that they were apathetic. They literally, once the diagnosis of West Nile virus, it's almost comical, because once you have the diagnosis, I mean, you go from being on 4 antibiotics, and next morning when they get they stop the 4 antibiotics, or 3 or 4 multiple antibiotics to ward off the bacterial infection that you never had, and then then they send you home, okay, and then you're discharged. And so I wish that were the case. Now, I'll tell you, slowly we're making some progress. So yesterday I got a call from a internist in Indiana, and he had a patient and had just had West Nile virus infection, and she had all these lingering symptoms that had been almost a month, and he wanted to know. He had read the article, Dr. Bush, the Lazarus effect. He read the article, and I said, I've never given this before. How do I do that? I said, look, I told him exactly how to give the corticosteroids. It's called Solumedrol, also generic name is methylprednisolone, and you give 1,000 milligrams a day for 5 days. You can give the infusion relatively quickly in the morning, 5 mornings in a row. And I said usually by the end of the first day or second day, we see some evidence of improvement. And notably, I've been doing this since 2002. I never got a call from anyone who said, I gave the steroids and my patient crashed. worse, my patient died, we had to intubate the patient, etc. Now, realistically, I tend to, in an acute case, I usually wait until I see some evidence of worsening. If I see the case acutely, like I'm seeing now for the first time, I used to be here at Methodist Rehab and waited for patients to come back to us. Now I have at least disease-specific privileges at a lot of the local hospitals. I go there and I'm able to see a patient, and if they're going to be alert and have, limited signs and symptoms, I probably will not start to put them on Solumedrol or glucocorticoids. On the other hand, when they drift from full alertness to stupor and they don't respond, or they develop any type of evidence that tells me that central nervous system is being, then I put them on high doses. I used to wait about 14 days in 2002, 2005, but more recently, I know based on this CDC work that once you have the neutralizing antibodies, which is translated, once you're diagnosed, you have to have neutralizing antibodies. And so right away, I recommend the steroid treatment.
Relates to what you were just saying, so I'll go ahead and ask it. It says,
Okay.
Since you've reported using high-dose steroids for a patient who was unresponsive, how long after the acute stage would steroids perhaps be useful for the post-infectious inflammatory state?
Yeah, that's a great question, and I'll tell you, about 2 years ago now, we had a patient who she was about 3 months after the acute infection, and she had developed the poliomyelitis variant, and then she started getting weak again. So she had difficulty lifting her leg up off the and so I treated her with 5 days, and she got better. This was about 3 months afterwards. Now, I will tell you, a lot of the literature, the myasthenia gravis literature, for example, that developed in all 6 cases from 3 to 7 months after the acute illness. And this patient who went from a stable ocular myasthenia gravis to a full myasthenia gravis crisis did so about 3 months after, 3 or 4 months after the acute illness. And based on the Houston group, I mean, you can have elevated cytokines 5 years later. So I would say to you, there's no time limit. If a patient, a year later has disabling fatigue, I would do 2 things. I would order a cytokine panel. Cytokine, I usually get this at Mayo Clinic, but there are other cytokine panels available. And I would also order something called S as in Sam, S100B as in boy, S100B. And then I would sometimes allow that to guide my treatment. The cytokine panel looks at 14 or 15 of the most common cytokines, and I have seen that we have groups of patients, exactly what the Houston group found, that patients do have elevated pro-inflammatory cytokines. If they do, I would treat at any time. If I don't have the luxury of, or the hospital doesn't do these type of panels to Mayo Clinic, I would say I would do it anyhow. High dose Solumedrol is a relatively benign treatment. In prior years, we for 30 years, we've used it as a mainstay, the immunotherapy, for treatment of multiple sclerosis. It's not new. It had to be decades, we've used another powerful steroid called Decadron for treating patients who had brain tumors and had a lot of swelling and edema with those brain tumors. I kid you not. I mean, literally overnight, those deep stupor to going home with a brain tumor just from the one dose of Decadron. So this is not entirely new, and there's a whole lot of literature on DNA viruses. And so no time limit. Suspect they have this prolonged pro-inflammatory state. I would give them a yes, in the back. Yeah. If so, what happens is that patients do come in. I had one who was actually 3+ years removed, and she had a constellation of symptoms that to me suggested exactly that. She felt like she had a lot of fatigue. It was disabling. She kept getting kind of recurrent headaches. She felt like she was always walking around with a low-grade fever. She had joint aches and pains, sometimes muscle aches and pains. And the rheumatologist really never gave her a diagnosis of the fibromyalgias. And so I did treat her, and that was about 3.5 years removed from the infection. No, it doesn't. Not really. I would say steroids are acute, high dose steroids are harmless enough. Chronic steroids are a pain. Okay? But I have a lot of patients on chronic steroids, and sometimes for a year. And that's not my choosing. It's sometimes insurance companies that, I'm thinking I'm going to transition this patient from methotrexate to rituximab, a newer immunotherapy agent, and they get denied. And then I have to go back, high dose oral steroids because they're losing control of their autoimmune disease. And so, your question again? Oh, okay. No, I would base it on symptoms. Yes. No, it just means that the Houston data, 5 years. Is that the limit, or is there something else? Which just means that they have to do a 10-year study. and I hope that they're listening. Okay, we can talk later.
The protocol, medical, from the West sooner, and waiting to somebody become definitely ill.
Okay, so the question is, how do you get a protocol out in the community, really to the doctor's first line caregivers to check for West Nile virus? Again, you gotta love the Houston group. Okay, so they did look. They did, and also Arizona did a large scale studies, and I think Houston did it for a number of years, a 5-year period. And I got to tell you, even with the 2 programs right there, and they published a whole lot on West Nile, the reality was the majority of cases of undiagnosed encephalitis got checked for West Nile. Within a percentage point or 2, the group from metropolitan Phoenix area, the 6 area hospitals, they had pretty much the same numbers. So I mean, I think we're slowly making some inroads, but the counter argument would be, what the heck is taking so long? I can't.
Who can run a test on this now?
Anyone, every lab virtually can run it at this point. Okay, most large labs can do it. The health department, yes, yes.
The health department is, the health department is only for surveillance, not a diagnostic test. They just basically do theirs for surveillance, to know what we have in the state. The government, they send our tests off to Maryland?
Yeah, I sent your tests off to Mayo because I include the cytokine panel, the S100B.
And on blood and on serum and,
I don't know about spinal fluid.
I wouldn't like, you know, some.
So you had actually positive in both, if I recall correctly.
You mentioned mosquito control being, but
Yeah.
any suggestions on how to communicate with all these states? My town, they don't want to say, that's not a virus.
Okay, so we have a WMV survivor who from Tuscaloosa. Okay, no. Who made the comment that you know, sometimes municipalities don't want to admit that there are mosquitoes galore in your city back on tourism. I hate to hit a neighboring territory when they're already down, but I read an article. Actually, I got a call from a reporter in the East Coast going to write a review on success, the striking success of Rico's mosquito control program. The reality is there's no right or wrong here, believe me, because in 2012 they had an epidemic. I think it was dengue, and then again in 2014 they had a dengue and another mosquito-borne disease. But 2014 was actually a epidemic, and they were barely from the dengue. I think it was dengue and chikungunya epidemic in 2014, and they lost millions of dollars in tourism. 2014. They were barely recovering when what happened in 2016? Zika. Zika came in and essentially they had like 20,000 cases. Puerto Rico's not that big. So they had this tremendous epidemic that had already instilled fear. There were some Olympians who didn't attend the Olympics. A lot of people who didn't go to Brazil for the Olympics because of the fear of Zika, particularly young women. That was 2016, and they did what they had to survive. 2016, just months later, what happens? And what was the large hurricane? I can't remember. Two back-to-back hurricanes. Maria, yes. Two back-to-back hurricanes, and the last one devastated the island. I mean, we were there, and entire sides of mountains had eroded away. No roads built. And I've been to Puerto Rico maybe 4 or 5 times, and I'm going again next month. They have They have infrastructure problems. They also now, because of the repetitive nature of all these disasters, they also have an exodus of a lot of moved away. And the reality is, I read that knowing what this was about, and I said, look, do you want my version of the reality of what's going on, or do you just want me to report it? The reality is, Puerto Rico is doing what it has to. I kind of wish they could receive more funding from our government. They're a U.S. territory. I would advocate that, but let me tell you, they don't get tourism money. They perish. They're an island. It's a simple reality. And so, but even before that, if you look at the string of Caribbean islands, there's a 2,000-mile string of islands that goes into the Caribbean. And any given year, you will see that, let's say let's concentrate on 20 islands in a island chain. About 4 or 5 of them will have no reported cases, whereas the island to the left of you had 1,000 cases, the island to the right of you had 12,000 cases, no reported cases. So what's going on there? There is essentially they're not going to do anything to jeopardize money. And a lot of times that's their number one money generator. Beaches are absolutely beautiful in San Juan and Puerto Rico.
Health department is there, there's our whole state that is at that meeting. And they pretty much know you already. But I would suggest going to that meeting. That's their job. Yeah.
I guess we'll go ahead and any last questions? Well, thank you all for attending. I really appreciate it. And thank you all out there for listening.
Yes.